Hey guys, welcome to our CME. I'm going to go ahead and get started here. A couple of housekeeping things that I just want to remind you of before I introduce our presenter is where this is virtual, please make sure that you have muted your microphone so we don't have any feedback when Dr. Hopkins presents. And then if you have questions, with anything during the presentation, then please feel free to be able to put it in the chat box. Morgan and I will be watching that throughout the presentation, and if it's something we need to chime in and ask Dr. Hopkins, we will. If not, the questions we'll save for the end for Dr. Hopkins to answer at that time frame. Also, just a reminder that in order to get your actual CME as a physician, at the very end, I will display a QR code on screen. Please take a picture of it, fill out the evaluation at the end, send us to that. That evaluation will stay open for 3 weeks, and then we'll close at that time frame. And then this will be recorded and posted onto the intranet underneath continuing medical education when we get done. It does, please give us about a week to be able to get everything. We've got to go through IT to get everything posted, so it does take some time. So with that being said, I want to introduce our presenter today, which is Dr. Hopkins. He joined Bingham Healthcare with us back in January of this year, 2022, and we're super excited to be able to have him join. He brings a lot to Bingham's table. He is a DO, and he specializes in addiction and family practice medicine. He also has a side hobby as a field surgeon in the military and goes down to Utah once a month to practice and do those things as well. He gained a true interest during his residency on behavioral health and addiction medicine, and he'll share some of that story in his presentation. But without further ado, we want to turn the time over to Dr. Hopkins, and we'll take a listen. Thanks for joining.
All right, thank you, Tara. It's good to be with y'all today. I'm quite nervous about this, so please bear with me. Just want to, thank you, Tara, for the introduction. But yeah, like I said, I'm Brian Hopkins. I'm actually originally from Firth, so I grew up here and went to ISU for undergrad. And so went down to the Alabama, Florida Panhandle area for school and residency. And I got tired of the warm summer sandy beaches, so I decided to come back up here. So everyone at Bingham has just been so wonderful in welcoming me. So, individually, you're not scary, but collectively all are. So, I get nervous about this, but we're going to be okay. So thank you for that. And yeah, my true interest in addiction medicine was actually more of an accident than anything. In our residency program, we were allowed to moonlight and such. And so between my end of my second year of residency, I'd say, I was hired on to work at a center called Behavioral Health Group, which was fairly nationwide. And is primarily opioid use disorder, although they deal with others as well. And I was getting involved because I was looking forward to, make a little extra money on the side. And it actually happened that I truly enjoyed the work, and I was seeing the impact that I was playing and being part of their recovery, and became really rewarding. So I didn't want to lose that. And so today here at Bingham, I do practice primary care as well as addiction medicine. And today we're going to discuss more about opioid use disorder. And, we hear about that all over the news and everything. And it seems like we're well aware about the epidemic and everything regarding opioid use disorder in this country. So I guess I probably see if we can figure this out here. So I don't have any disclosures to make, no financial disclosures. This is a very broad topic. And so when we talk about opioid use disorder, we're not talking about utilization of opioids for pain per se. And we'll get more into the weeds of like what is opioid disorder versus chronic pain a little bit, and when is it truly opioid disorder. So, like I said, no financial disclosures, although I'm always open to suggestions there. So, all right. So here's our outline for the day. We're going to go over a little bit of the opioid use trends and consequences. currently and in the past through particularly our country, and its history, the regulations, and we'll get a little bit of the neurobiology, discuss when a patient is intoxicated, and it's kind of some of the withdrawal signs. And then the what I'd really like to hit is the medication assisted treatment, or MAT. In this case, we call it also MOUD, which is medication for opioid use disorder. Let's see, and here's our objectives. So the three main ones for the CME, for CME credit here is, so understand the history of the opioids, opioid misuse, and legal action in the United States regarding opioids. Assess the high-risk patients, identify risks for misuse and implement strategies to reduce harm, and analyze the 3 FDA-approved medications for opioid use disorder and recognize when it's appropriate to use for treatment. The real end goal for me is that even if you don't want to do MAT or treat for addiction, just it's more of recognition, and also to be a little bit more educated and have a little bit more confidence with regards to these medications, and not to be afraid of them. So here, this is, just for regarding just for the trends and everything within our country. This isn't a electoral map college. Idaho is still red last I checked, but no. But with substance use disorder, it affects millions of people. They say about 40 million. That includes, we include tobacco in there too, which is a huge chunk. Alcohol as well, marijuana, opioid stimulants, sedative, hypnotics, those sorts of things. The estimated costs annually is about $740 billion, which is incredible. And that includes, in opioids, for the opioids part, is about 78.5 billion. So that would include like crime, lost work productivity, healthcare costs, etc. So that's an enormous amount. You think about it's closing in on 1 trillion, and that's a big chunk of our GDP. Substance use disorder is now more common than diabetes, and 1.5 times more common than all cancers combined. From 1999 to 2017, more than 700,000 people have died from a drug overdose. So this is just, like I said, this is a snapshot and general overview for substance use disorder. And then on the bottom right-hand corner, it's kind of more pertaining to Idaho in 2020. And just kind of get you an idea, Idaho is below average, which is always good. The national for the overall drug mortality, national is about 20 and a half persons for 100,000 people. In Idaho, it's 18. So we're kind of getting closer to the average mark, though. A little bit more about pertaining more to Idaho, a point is kind of how, they talk in the streets and everything, but a point of heroin costs about $20 in Pocatello. So you think about it, that's 100 milligrams of diacetylmorphine, and, heroin's about twice more potent than than morphine. So you're looking at, if you kind of think about it, if you will, it's like 200 milligrams of morphine in a way. So, in a regular user, they'll go through 3 to 10 points per day. So, $60 to $200 per day habit. And then, but, right now, just like any other economics, the flood of heroin that's coming through from across the border has dropped its price. So you think of like the opioid pills and everything, that, those are going up, and really it's just too expensive, a little bit more challenging to obtain now, especially since physicians and providers are not prescribing these as much. So yeah, like an Oxycontin tablet's about $100 per pill, and it's just cheaper to get the heroin now, unfortunately. So, and patients don't want to buy too much in case they get caught. If they get caught with too much, it would be more of a trafficking charge, and so they want to avoid that. And so they're always so because of that, they're always going through withdrawals. It's just part of their life, unfortunately, and they're just looking for that next fix. And so so during that time, if you think about it, they're not being good members to society when it comes to employment, and and then just in and out revolving door through our judicial system and ERs, and it's can be quite burdensome, and as like I mentioned, quite costly as well. So going through this, the drug-related arrests, personal and social costs. So any possession of any amount of heroin, cocaine, LSD, and meth is a felony. Okay, 2 grams, which is 20 points, if you will. Marijuana, cocaine, and meth. That's all trafficking, so that's a worse charge. And unfortunately, the consequences of a felony here, particularly in Idaho, is it's tough to recover from. I mean, of course, they get the prison time. They don't get any financial aid. They're ineligible to vote. No food stamps, public housing. If they do get a job opportunity, less likely they'll be asked to come back for an interview just because of that history. So it's extremely difficult for these patients to recover and be integrated back into society. So, and of course, infectious diseases. We always think about, if they've been in prison, the first thing that comes to my mind, particularly, is hepatitis and TB. But, HIV and STD are definitely up there as well. So 2018, 46% of the federal prison population, they're there for drug charges, their most serious offense. So it would be, if we could address this a little bit more appropriately, hopefully that we can reduce the amount of burden to our prison system as well as to our communities. Incredibly and sadly, the U.S., we've probably heard about all this, but they broke over 100,000 lethal overdoses from April 2020 to 2021, and about 2/3 of those were involved with opioids. Actually, it's more about 70%, and then 2/3 involved with the fentanyl, and we've been hearing about that. So as we've been cracking down on the opioid prescribing, and we think of the OxyContin issue, and if anyone's seen Dope Sick, you'll kind of understand that as well. But you see an increase in the heroin users, incredibly by 100% from 2004 to 2016. But from 2010 to 2016, it was over 500%. So it is just exponential. It's just climbing. And incredibly, 4 out of the 5 recent heroin users were previously abusing prescription opioids. So not necessarily because providers were prescribing them, but that's what they first started out with, and that was pretty much the gateway to heroin. I didn't list it here, but overdose deaths with like psychostimulants like methamphetamine, cocaine, they've also increased because they're lacing fentanyl since 2015. So yeah, like a 45% increase. So it's a problem. It's pretty much what I'm getting at. So, and this is something that kind of blew my mind, and I was surprised, and maybe not surprised, but 70 to 80% of fentanyl that our authorities have seized between 2014 and 2019 have actually originated from China. Most are smuggled through Mexico, although there are some from Canada, and there are some that are directly sent to the United States. So, and with the borders and everything being an issue right now, it's not going to get any better anytime soon, unfortunately. And then down here, I just have El Chapo down here, arrested as well. So, all right. So moving forward, just with prescription opioids, make a little transition. So anyone who takes opioids can be at risk for addiction, accidental overdose, or death. So don't think that just because they come from a good family or they would never do such a thing. That's not that anyone is at risk. And there's a little bit more risk for those for an overdose, particularly not necessarily abuse, but overdose for those patients that they live alone. They drink alcohol, the benzos or barbiturates. Soma is a big one. Broken down, that's more of a barbiturate. And of course, we see that if they're taking more than they've prescribed. And then the big what I see is that patients will they'll they'll be clean and they'll go for a little bit and then they'll have a relapse, and unfortunately they'll go back to the amount that they were previously on to get back to their fix, and unfortunately it's just too much for them, and their tolerance has decreased, but when they take the same amount, it can be quite lethal. So so a patient with opioid use disorder. Now, this isn't for those patients that take opioids for, and they're taken as prescribed for chronic pain. This is for folks that truly have opioid use disorder. About 45% of them, they have an incidence of a non-fatal overdose in their lifetime. And about 18% over the past year. And a lot of, and there'll be some witness around 70%. So it's a real issue. That picture there is actually Narcan. That's the nasal spray. And we're going to go into more details about that, but that's just an illustration on how to use Narcan, which is quite easy and it's really underutilized. So this is just coming from the CDC. It's a little cartoon schematic, and I really like it. It's real informative, and it's more for us as providers, that anyone who prescribes opioids, and just some techniques to and actions for safer opioid prescribing. Number one, I mean, we don't need to write that many. Most of the time, NSAIDs, Tylenol, physical therapy, exercise, and shoot, even CBT, we can use a lot more within our practice. We can write for fewer days. 3 days or less is often enough. And honestly, like if we prescribe so much opioids, let's say like we do a post-op, I don't know, whatever procedure, you name it, and you give them, 90 tablets, essentially you're talking to them, implicitly that, this is going to be a painful process. And also, these patients not only will think, oh, this is going to be really painful, it's going to be a long recovery, for milder pain, they're going to be a little bit more apt to take that next opioid instead of, oh, I'm going to save it for later for real severe breakthrough pain. So, writing fewer amounts, it definitely decreases the risk for potentially abuse. Another thing that I want to talk about is the morphine milliequivalents. Now, we're just writing lower doses. So, and on the next, I think it's the next screen, but we'll go over how to calculate MME. But a dose of 50 MME or more doubles the opioid overdose death compared to 20 MME or less per day. So at 90 MME, the risk increases by 10 times. So a 90 MME for a opioid naive patient is lethal. So, and consider other factors too, the patient, their socioeconomic status, unfortunately, they're in poverty, they're at higher risk for abusing, or potentially becoming, have the diagnosis of opioid use disorder, unemployment, family or personal history of substance use, a young age, history of criminal activity, heavy tobacco use, thrill seeking, just any of that. There in the bottom left corner, I just mentioned some other utilizations that we should use. And I recommend this for anyone who prescribes opioids, but I always checked Idaho PNP, and I would recommend selecting Wyoming, Montana, and Utah for neighboring states, and see, are they going anywhere else for any of their opioid refills, urine drug screenings, same pharmacy, limit to one prescriber, and so forth. So, all right, yeah, here's an example of how to calculate an MME, morphine milligram equivalent. And if you can just look here on the side where I put for Norco, let's just say that's commonly prescribed, 10 milligrams of hydrocodone. And if you look at the charts, about 1 MME. So 10 milligrams of hydrocodone is equivalent to 10 MME. So if you take that 4 times throughout the day, you're already at 40. And like I said, 50, puts you at risk. It doubles the risk compared to 20. And Percocet, we see that, 10 milligrams, that's about 1.5 times for each milligram for the MME calculation. And then you're already over 50, you're at 60. And I put Dilaudid there as well. So this is a handy chart to have. And just for comparison, methadone is really tricky, and it just really depends on how much they're taking per day. But even with methadone, I just would not trust the conversion factors as much. But with methadone, anything over, if they're taking, more than, I'd say 30, I would consider a Narcan. 30 milligrams, I'd consider a Narcan prescription to have and carry with them. So, but yeah, anything over 50, I would consider a Narcan nasal spray, especially as the risks I previously discussed. And then over 90, you just do it. And pharmacists here in Idaho can prescribe Narcan, and it's strongly encouraged as well. And so let's see here. So here are some other opportunities to reduce the risk for opioid use disorder. So the patient themselves, they can get educated. They have the Narcan. Go have some MAT, which we'll talk about, psychotherapy, counseling, family and friends, education. Again, carry the Narcan. What really got me really involved in this is, when I was first starting out, I had a patient that was previously on IV heroin, and anytime that a patient is abusing heroin, particularly IV, I'll prescribe Narcan. And this young kid, I think it was 19 or something, but I saw him one day, and I didn't know how serious he was, but we were going to transition him to, I believe it was to buprenorphine, Suboxone, but instead he used and he overdosed, but his dad found him, and he reversed him with the Narcan I prescribed. And then the next week, they both came in, and it was quite an emotional event. And but Narcan saves lives. I would definitely recommend it. It's definitely underutilized, and it does not encourage further use. It does not. So community, reduce the stigma. This is a chronic disease. This is not a moral failure. And then of course, we're talking about for us prescribers, education, as we're going to talk about today, Narcan, MAT, coordinate treatment, and then screen, look for it. So, and the government, they have their things as well, but really we just need better coverage for this, and for mental health, of course. So this is about harm reduction, and this is kind of like this is, I don't know, the real popular term right now within ASAM, which is American Society of Addiction Medicine, who is our governing body essentially. But harm reduction is, like I said, it's what we're talking about all the time. And one thing that I've always kind of like struggled with is like, are we enabling these patients? And it can be tough to agree on some of these things, providing clean, syringes and, all these exchanges and such. There are even some parts in Europe, and I think Oregon's even discussing about having centers where they can use, but they can be monitored and watched over as they use, and that's, like, how far do we go with all this? It's tough to say, but definitely for harm reduction, getting a patient on buprenorphine or methadone, we'll talk about that as well, and there's naloxone as well. So it's just a middle ground. If they're going to use, let's try to reduce their harm as much as we can. So a little bit of the history. We all heard of opium, and and where it came from and everything, but about 7 to 25% of the poppy is actually the morphine, and a little bit of codeine in there. Another one's thebaine, which is about 1 to 6%. That's used for the synthesis for like synthetic opioids like buprenorphine, hydrocodone, and such. Poppy seeds, and I've always been scared of having a poppy seed muffin, but you could, in theory. On the skin of the poppy seeds, there's a little bit of opium. In fact, haven't seen it too much in this area, but you can have what's poppy seed tea, have a little lemon juice, water, and such, and you could actually get addicted to that as well for opioid use, and you can go through withdrawals from there, and it can put you into some bad parts too. So a little bit out of the history. So opium's been around forever. It was referred as the joy plant, as far back as 3400 BC. Just for my OB friends out there, this is where meconium was derived from it, actually. So Aristotle believed that meconium is what induced sleep in the fetus. And so when it comes to raw opium, it has that black tarry appearance. For the longest time, it was just primarily smoked in China and East Asia. And then during the gold rush, 1849, such California, a lot of folks from East Asia, China, they came over to work in California, and they brought opium with them. And that's really when it really started to take off a little bit in the United States. But morphine was then isolated from opium in 1803, and that was 10 times more stronger than the opium. And so in 1853, they came with the hypodermic needle, and so in Civil War, it was utilized quite a bit and caused a lot of issues with with our veterans and such that were taking it, morphine. And then we eventually got into problems later on in the late 1800s. So in 1874, scientists began to look for a less addictive form of morphine, and that's how we got heroin, which is not less addictive than morphine, but it was sold that way and it was marketed that way. It was actually commercialized by Bayer Pharmaceuticals. Think of Bayer aspirin, the same. So it was supposed to be a substitute in 1895. And believe it or not, diacetylmorphine heroin, it actually has a trade name called diamorphine, and still being used in a lot of parts of the country, although it is limited and depending on their laws, regulations, and everything. So I just have just 3 pictures, on the bottom. That's actually not heroin, that's laudanum. It's just a tincture of morphine and codeine, but that's what Wyatt Earp's common law wife, Maddie, was addicted to. And she actually overdosed with that in 1888. And then I really like how these other 2, they're just like they're just the snake oil to fix everything. But the bottom right, you have heroin, alcohol, and chloroform. It sounds like a good mix. Advertised as the best and safest cough remedy for diseases and ailments of the lungs and throat. So anyway, well, we saw some issues with it. And so, the U.S. government got involved, and so in this case, there was some good elements about that. So the Pure Food and Drug Act, that was real important. That really changed things around. So now we actually know what's in it, supposedly. That was the idea. We had to label ingredients of all medications. And just that alone, it decreased the use by 33% with these mandated labels. The Harrison Narcotics Act limited the opiates just by prescription only, and so you couldn't find that over the counter anymore. And then in 1919, the Supreme Court decided that physicians could not prescribe opioids for treatment for addiction. It was not allowed, but later on they reversed that and stated that you can use opioids to treat opioid addiction. So just kind of further along, we have the Controlled Substance Act, which we're fairly familiar with for most of our medication with all the scheduled drugs. And they added the Narcotic Treatment Act, 1974, and then the Data 2000. This is where it really comes in for addiction medicine. So this was an amendment to the Controlled Substance Act. And so this is when you started using, like, we'll talk about the buprenorphine, particularly, where you have to get an X waiver to prescribe for addiction. So the idea here was that, hey, if this doesn't work, we'll just rescind this amendment to the Controlled Substance Act, and it won't be a big deal. So they kind of just slowly carry this out. So with buprenorphine, they weren't so entirely sure how effective this would be for opioid use disorder. So, and they limited the prescription to only 30 patients per physician. That it increased to 100 patients in 2006, and then 2016 they started to really expand it. They allowed physician assistants and nurse practitioners to qualify after a 24-hour training. And then they also increased the limit to 275 patients at one time. So that's active prescriptions of buprenorphine. And so further on, now they allow clinical nurse specialists, nurse anesthetists, and midwives to now be able to prescribe it now. And so because of COVID, they allow telemedicine, and that's actually still in effect. But now, last year, they allowed, so you don't even have to do the class. You can just go into the just to that website there, click it, and you just do a waiver, and allows providers to go up to 30 patients. So if an emergency medicine physician sees this and they're in active withdrawal, they could actually start a patient on buprenorphine, have them follow up with a MAT provider, and they can stabilize them in the ER with this medicine, give them a 3-day supply, and then have them follow up. So, and that was the goal there, was to kind of stop the cycling door. So just a little bit of terminology moving forward. So endorphins, that's the ligand that, everything that makes you feel better and everything buying, from the mu opioid receptor. And opioid versus opiate. Now, opiates are, compounds that are naturally derived from the poppy plant. So morphine, codeine, heroin, thebaine, opium. And then opioid is really the semi-synthetics and the synthetics, but now really today it really just kind of includes all of opiates plus the synthetic, semi-synthetics. So kind of in just crosstalk. So it's, if you want to get into details, you can, I suppose. But anyway, just more of the opioid and opioid receptors. What we're going to really focus on is the mu opioid receptor, and that's what's associated with addiction and withdrawal intolerance, particularly analgesia and euphoria. So just a little bit of biochemistry that I'm not going to go in much detail about, really, but just in general, what we just want to get from this is that it causes, inhibits the GABA in the VTA, the ventral tegmental area. You get a surge of that dopamine in that mesolimbic system, and that's what makes you just feel good. That's how we get these tolerance, withdrawal, and just addiction overall. So the mu receptor is actually activated from cannabinoids and alcohol as well. And so that's why you see, for treatment of alcohol use disorder, you'll treat with naltrexone, which is a mu opioid antagonist. So it actually helps with the alcohol use. So that's why we use that and why it makes sense for that. But essentially, the mu opioid receptor is what we care about the most, and that involves the physiologic effects of intoxication and withdrawal. So just some additional opioid effects. This eye kind of freaks me out, but like I said, CNS sedation, analgesia, euphoria. We talked about that. GI constipation, opioid-induced constipation. We see that a lot. We see it also with this, and this is underdiagnosed, but decreased testosterone, increased prolactin from chronic opioid use, and that's why you get that from alcohol, heavy alcohol use as well. Urinary retention, of course, vasodilation, and increased QTC, particularly with those longer acting opioids, including like methadone and such too. And of course, the pinpoint needle, pupil. So here's just like a sample for a urine drug testing. And just to keep in mind, when we're doing a urine drug test, and we see opiate is negative, it doesn't mean that they're not taking opioids. Fentanyl does not pop up on a typical urine drug screen unless you're actually looking for it, for example. So I, working in the ER and during residency and moonlighting and such, I'd get that all the time. Like, well, they tested negative for opiates, and oxymorphone is the other one, but that doesn't mean they don't have fentanyl. The history and the physical exam. A lot of times you just go for that Narcan and see what happens, if you have to. So, yeah, like I said, fentanyl, buprenorphine, and methadone, they just don't show up on a typical test. So you have to be specific and actually look for it. So here's just an idea for the potency of opioids, compared to morphine, and the size of how much. So of course, there's the diacetylmorphine, which is heroin. It's 2 times the potency of morphine, and it moves up. So fentanyl is about 100 times, up to 100 times more potent than morphine. And as you can see, it's about the size of a sesame seed. So buying a little bit of fentanyl that's a sesame seed, and actually, take or consuming a sesame seed full of fentanyl is a lethal dose. So it doesn't take much. It doesn't take much at all, especially if they're naive. The others, sufentanil, carfentanil, I mean, unless you're hunting elephants or bears, we just don't use it, but that's there just kind of a comparison. So opioid overdose, the classic triad, the meiosis, and just with prolonged low blood oxygen levels, you get the meiosis going on. Of course, you get the decreased level of consciousness, coma, and then respiratory depression. And then, of course, you can also see pulmonary edema and seizures, particularly with like tramadol. And just a little bit of management for opioid overdose. We talked a little bit about Narcan, and that's what it is. So is naloxone. So naloxone is the short-acting reversal agent for opioid overdose. So in particularly in the outpatient setting, I prefer the nasal. It's easy to use, but with fentanyl and everything, you just can't be afraid to use it. Even 2 sprays, even up to 8 milligrams in one setting before EMS arrives. And like I said, again, this is a take home is, if we have 50 MME per day or higher, I would highly recommend it. If it's 90, you just do it. You just do it, especially, if they're on benzos or have a history of abuse, you just have to do it. Here's some just other pitfalls from opioid analgesic overdose. And this is kind of something I guess I learned too recently, but of course, for the fentanyl patch, if it gets all heated up, that's going to be a problem. In the summers, they're on fentanyl patch, they're going to get more of the fentanyl. Something with anesthesia, they'll know that, you get that chest wall muscle rigidity with the fentanyl use. And then, repeated naloxone, may be needed for like methadone or fentanyl. Overall, fentanyl is my arch nemesis in medicine. It's my least favorite. We're talking about, the transdermal fentanyl, increases absorption. And that's for any patch, including butrans, which is buprenorphine, but that's indicated for chronic pain. Meperidine, Demerol, tramadol. You always have to consider the seizure threshold, serotonin syndrome. So go into a little bit of kratom. So here in Idaho, it's primarily kratom I see that patients will utilize to try to take off the edge of their opioid withdrawal. Not so much as tianeptine is probably something that not a lot of us heard of, but in the South, it was used all the time. And it was commercialized as a herbal stimulant and legal in most states. But it's just marketed as an antidepressant, it's like a St. John's wort essentially, but at high doses, it actually binds to the mu opioid receptor. And so kratom, it actually doesn't bind to the mu as strongly. It's actually more antagonistic, but at higher doses it can be. But Imodium and Delsum, I have those two, also at very high doses, they can bind to the mu opioid receptor. But you know, I've had patients that are like, I've heard of like they'll take up to 100 milligrams of Imodium, which is absolutely insane, just throughout the day, just to be able to satisfy their well, their cravings and control their withdrawals. Just some symptoms for opioid withdrawal. You know, typically about 12 hours after stopping short-acting opioid, including like heroin. You know, dysphoric mood, nausea, vomiting, muscle aches. They get like kind of a runny nose. Essentially, essentially what I try to explain to my medical students, it's like, think flu. I mean, really, and really uncomfortable, body aches. They feel like they're going to die if it's real severe. But flu with a little bit of yawning, essentially, and a little bit more moody. Just really uncomfortable. And how we kind of determine, this is our universal standardized tool to assess withdrawal. But it's the COWS score. So this is how I communicate with other addiction medicine providers, and for for inpatient and such if necessary. But I just count by 12 essentially. Between like mild, moderate, and severe. It's kind of how I determine that. And when we get into it, the COWS score, you want to start, they say it depends on who you read, but 7 or 8. And I don't know if I have no, I don't. I wish I had a copy of the COWS score, but essentially it assesses all these symptoms here, with a little bit of the hemodynamics, blood pressure, pulse rate, all that sort of thing. So, anyway, you can use the MD Calc app, and it's readily able to use. But a score of 8 or higher, that's when we need to start the buprenorphine, is what I recommend, or as uncomfortable as possible. And so when you're in the room with these patients, this is what I like to use for it's called SBIRT. This is how we screen. So screen them, brief intervention, do a little ORS mnemonic is how I remember, open-ended questions, affirmation, reflective listening, summarizing. So just pretty much help the patient realize that they got a problem, and then referral to treatment. There's really no standardized screening for opioid disorder. Not like CAGE or the Audit C or anything like for alcohol, but we just primarily use COWS for the withdrawal, and then just screen them with this SBIRT here. And this is how I really determine, who has opioid disorder. So versus those patients that are on chronic opioids for pain. So for me, it's, do they have withdrawal and tolerance? Okay. And really you only need 2 of these check marks in order to have opioid use disorder, but not withdrawal and tolerance, and that's it. Because they can be seeing like I said, a pain management, and they're okay. They're taking their medicine as prescribed or whatever. But when you term the addiction term, or the opioid use disorder, that's when it's like it's being abused. So, and I just remember about the 5 C's. All right. So like the loss of control, are there consequences, financial, family, work consequences? Are they injecting? If they're injecting, it's automatic. I mean, they're putting a foreign body in their body. Compulsion, and there's a little gray area for cravings. So I don't count that as much. It's kind of a judgment call there. But if they're unable to cut back and they desire to cut back, so that's all part of it. So in the DSM-4, 2 to 3 symptoms would be considered opioid abuse or substance abuse. You can just plug and play essentially with the substance. So it's opioid or substance, methamphetamine or whatever, but the same thing applies for all substances here. But yeah, 2 to 3. So historically in DSM-4, that's substance abuse, while as 4 or higher is considered substance dependence. So if you see that in the DSM-5, it's all substance use disorder, and you treat it the same, but it just gives you an idea of how severe this is. So the role of MAT, medication-assisted treatment, with OUD, is just to prevent, from overdose, essentially. And it's actually possible reversal. I've actually had a colleague that actually reversed a patient. So patient and his girlfriend, the girlfriend brought her boyfriend who overdosed, was shown the classic, the triad, and took it over to the office instead of the ER. I don't know why, but they went there, they called the EMS, and they actually gave the patient sublingual Suboxone. It was his prescription, but he overdosed. He relapsed, and it actually reversed him. So by the time the EMS arrived, he was actually doing much better. Of course, he went to the ER for further monitoring. But MAT, it stabilizes that the withdrawal symptoms as well as those cravings can be real horrific. So, and with MAT, again, it's back to harm reduction. You reduce the risk for HIV, Hep C. These people are going back to work again. They're not being a burden to our prisons, our law enforcement. It's just it's such a life changer for these people. And so these are the FDA approved medications for opioid use disorder. We talk about, our focus is going to be more on buprenorphine. Methadone, it's been tried true. It's been around since 1966. It's been a while, for a long time. But the nearest center where they actually treat for opioid disorder, which they call OTP, opioid treatment program, is actually in Boise. So I have had a couple of patients that have come this way who was on methadone, but moved out here, and so I had to transition to buprenorphine. But methadone, you can prescribe it as for chronic pain, but for opioid use disorder, they have to go through these programs, which is, they just have to essentially show up every day. They call it liquid handcuffs, but that's kind of a terrible term, but it actually helps these patients with their, prevent them from relapsing. But buprenorphine is really what I want to focus on. It is an opioid. And so and it definitely has, the abuse potential, although it's much less. You have the withdrawal tolerance, all those things, but it's a partial agonist. And the biggest deal there, it's got a ceiling effect for respiratory depression. And that's the biggest deal. And so it's only if you take it with other like benzodiazepines or whatever that you can get into some trouble. But buprenorphine is used for opioid disorder as well as chronic pain. But when it comes to, and we're only going to talk about opioid use disorder today, but sublingual buprenorphine is the most common form for opioid use disorder. And then the third is naltrexone, and that's a full opioid antagonist. And we'll go from there. But there's some other medications I use to help, clonidine, NSAIDs, Imodium, benzos rarely, but it can be used in a very if you're monitoring them closely. And so here's just a little schematic between a full agonist, a partial agonist, and a naltrexone. So here's buprenorphine, and then we'll just talk about the sublingual here. It's got a fairly long half-life. You actually don't, for most patients, if they just stop cold, it takes 2 or 3 days before they start having some withdrawal symptoms, like severe withdrawals. And a lot of times they feel better. They're like, I don't need to take it anymore. And then they can find themselves in troubles. You just got to consider, it can alter liver enzymes, although rare. And in pregnancy, particularly, historically, we've always just done buprenorphine without naloxone. But it's now safe now to use with naloxone in pregnancy, particularly with, so for that naloxone, that is the same naloxone that's in Narcan, but it is not active in Suboxone or in this formulation. It is only active. It's act as more of a deterrent than anything. So if the patient decides to vaporize and try to smoke Suboxone or dissolves the medication and decides to inject it, it is then activated and they do not receive any euphoria from its use. So patients won't abuse it. So buprenorphine has a real strong affinity. to the mu opioid receptor. And so it competes with other opioids. So if you think about it, if they're on fentanyl or heroin or whatever, I mean, they're going 100 miles an hour. You give them buprenorphine and you put them to 50 miles an hour, because this is a partial agonist, not the full effect. You put them right into withdrawal, and that's what we call precipitated withdrawal. So the benefit of this is if they're on buprenorphine and they decide to use, let's say, heroin particularly, and they're using Suboxone appropriately, it has no effect or very minimal effect. The caveat is fentanyl at higher doses can kick off buprenorphine, as that has a strong affinity as well. So when I think strong, I think of Mark Baker here. Oh, all right. Okay, so yeah, here's just a little bit of a curve here. So this is the ceiling effect for respiratory depression. So it increases by the dosage, but buprenorphine, it starts to even out. So even when you start taking more and more, you're not going to get more of that respiratory depression. You pretty much maximize out. So you can see how much safer that would be. But you can also see that if we're going from, the full agonist real high, and you're dropping them way fast, like I said, 100 miles an hour to 50 miles an hour, you can put them into that precipitated withdrawal. So before you start buprenorphine, you want to make sure, again, the COWS score is 8 or higher with the withdrawal. They need to have some withdrawal. Now, there's some caveats. I can do what's called the, like the micro induction method, or the Bernice method, which you just, like I said, microinduction, just give them a little bit at a time as they continue with their full opioid agonist, and slowly chip that away from its receptors. But it has to be highly watched over, monitored, and I don't do it too often, but I can. But you can bypass the whole going through withdrawal process. So, all right. So, like I said, moderate opioid withdrawal symptoms. I mean, you think of a COWS, close to 12, 8 to 12. Usually what I start with. If they're on fentanyl, though, or methadone, I usually wait, at least 72 hours. Or I even consider a little bit of more of a modified microinduction. Just give them just a smaller dose. So instead of slamming that brakes and going from 100 to 50, I just kind of tap the brakes as we go. And do that a little bit over time. So just kind of meet them in the middle. So they're going to have a little bit of cravings, they're going to have a little bit of withdrawals, but it won't be as severe as it could be. So this is just an idea, just my induction, how I typically do it. And like I said, it can be patient specific here, but 2 milligrams every 1 to 2 hours, just to help with that COWS for that first day. And usually I don't go any more than 12 milligrams on the first day. They're going to be a little uncomfortable, and you need to be upfront with your patients that, hey, this is going to be uncomfortable, but once we get there, it's going to be so much better. And then day 2, usually I just take the total of the first day and divide that in half. So if they took, let's say 12 milligrams, they maximize out on day 1, they take 6 milligrams in the morning, 6 milligrams at night. And then if they're continuing to have some symptoms, we go up to 8 milligrams twice a day, for example. But I usually write out 8 milligrams twice a day for the prescription, and then just give them those further instructions. There's also an app on a smartphone that you can use. If you have any questions, you can call me, but it talks through it with the patient on how to use these medications. Really helpful. So the buprenorphine has limited abuse potential. So based on those studies, compared to other opioids, it is there. And like I said, there's some diversion limits there too with the injection, with the naloxone available. So like I said, respiratory depression secondary to the ceiling effect. But consider if they're on benzodiazepine barbiturates, or they have alcohol use disorder, that those are concerning findings. But if they're already taking, a gobs amount of oxycodone or something off the streets, and it could be a real harm reduction. Just make sure that you mention that in your note. This just goes over some other buprenorphine. So it comes in, it actually have an implant, kind of like a Nexplanon. and usually about 8 milligrams or less. If they're stable on that, you can do this like implant right underneath the bicep muscle, but do that every 6 months. And then there's the monthly injection, which is what I prefer to put these patients on. It's just a subcutaneous injection in the abdomen, like an insulin shot or like a GLP-1, and they're covered for the month. So if they decide to relapse or whatever, they have protection there. So that's what I would like to gear towards. Here's naltrexone. This is the mu opioid antagonist. It binds to the receptor even stronger than buprenorphine and even fentanyl. It is it's really is limited to which patients can receive this. I mean, this is for patients that are like really motivated, highly motivated, and they do not display any opioid withdrawal symptoms. It doesn't take away any cravings or anything like that either, but this is used a lot of times in prisons, particularly in the United States, because if they use, it's just not going to work. And this is good for a whole month for the injection. So, but keep that in mind if these patients are, getting a vehicle accident or they're going to have surgery or whatever, you got to prepare adequately for that. So a lot of patients who take this for monthly injections, they'll have like a wristband or such to let EMS or know that they're on naltrexone. Here's the oral formulation. And then, like I said, there's one that's the injectable, and that lasts for a whole month. Before you get started on that, you can do what's called like a naloxone challenge just to see if they're truly going to have some withdrawals here. Methadone, like I said, it's been around forever. It was FDA approved in 1972 for opioid use disorder, but been around since '66 for pain. So the thing is, the big deal with methadone, it's got that NMDA antagonist. Essentially, you put them at the very beginning. You can definitely give them that euphoria, and you can go at that higher dose. And typically, patients, they'll start at 30 milligrams or so. When you march them up around 120, you're not going to see this here, but essentially, it just puts them into this state that they just take the methadone and they don't have that euphoria anymore. They just put it in this kind of plateaued state. But it is a full opioid. It is riskier than buprenorphine. I definitely prefer buprenorphine over methadone, but some patients cannot tolerate buprenorphine. And unfortunately, we don't have a center here, so you're pretty much limited anyway. But the biggest thing that we have to watch out for is the QTC prolongation. Again, it's part of the black box warning there. I just already talked about all these other doses here, its use. So again, this is just for selection considerations. Absence of harm reduction continuum, versus abstinence. Harm reduction is better than nothing. So, it benefits our society in a whole, not just the patient. So I highly recommend, if they're pregnant or planning on pregnancy, that was a bigger issue. But for our OBs, they want to know, particularly so we can avoid or just be aware that possible NAS is a situation. But buprenorphine decreases that risk for NAS, followed by methadone versus like other opioids. And just know about other psychiatric co-occurring disorders. These medicines can induce depression, anxiety, and that sort of thing. So just stabilize the opioid use, and then you can start digging in more on the psychiatric. But usually it's co-occurrent. And like I said, with the risk factors for developing opioid use disorder or substance use disorder in general, you're going to have, that is a risk, like I said. So, and this considers diversion risk and such. All right. So just remember that substance use disorder and opioid use disorder is a chronic disease, and it's a combination of genetics, physiology, environment, and behavior. And then just recount in summary that. About what we just kind of went over. In this country, about have 1.5 opioid overdose deaths every 15 minutes. So by my calculation, in the country, we've had 6 overdose deaths just during the duration of this talk. So anyway, Appreciate your attention. Any questions or anything?
Dr. Hopkins, I have a question for you.
Yes.
So when you're using your PMP, how often are you checking that? And are you looking just in the states that you mentioned?
Yeah.
Okay.
Yeah. So I check with every fill. I also do a urine drug screen with every fill as well.
Okay.
And I tell my patients, I expect especially the first one to be dirty. In fact, I expect the first few possibly. I don't tell them, that part that I expect them to be dirty. But the first one, I'm not going to like kick them out of the program or anything like that. But I expect it to be dirty. And as long as they're honest with me, we can have a good relationship here. But yeah, we do the urine drug screen with every visit, and then I always check the PMP. And I always select Utah and Wyoming in particular.
Okay.
Yeah, good question.
Another question is, so it's no secret that intravenous users and their risk of bloodborne pathogens. How do you handle and educate with intravenous users when we have no needle exchanges around? How are you combating that?
That's a challenge. So we as they don't like naturally we don't want to use these needles. I mean, it
Right.
causes pain, inflicts pain. So typically you get them on like a buprenorphine and stabilize. You control that. You control those cravings. You control that withdrawal. Typically, they won't use. But with that history, with every patient that comes in, I always check an HIV, hepatitis B, C, on them, and yeah, an HIV I think mentioned. And then if they have a history of IV drug use, I'm not afraid to check even yearly for that as well.
Okay.
But yeah, unfortunately, we don't have a clean needle exchange. Um, you know,
Yeah.
uh, you can mention to them. I mean, this goes on to the side of like, are we enabling them? I mean, because you can tell them, hey, you can actually buy clean needles at Walmart, for $2, for a pack of 10,
Yeah.
the insulin syringes. But like, are you encouraging its use? And that can be a challenge. But according to ASAM, it has not been shown to encourages these patients to use. So.
Okay, and there's been some empirical evidence about the different systems of dopamine response in men and women. Are you seeing a gender disparity where you have higher rates of opioid use disorder in males than females? Are you seeing that in clinic?
I really don't see a disparity in my clinic,
Okay.
It seems to be pretty much 50-50. Yeah. I would say that typically the males typically require a higher dose of buprenorphine, but that's not always the case.
Okay. Thank you so much for answering those questions, Dr. Hopkins.
Yeah, no problem. Anything else?
Any other questions for Dr. Hopkins at all? Okay, well, we've got the QR code on there. Please fill out your evaluation and send it to us. And we want to thank Dr. Hopkins for his time and for the knowledge that he gave all of us on our presentation. So thanks so much. Appreciate it.
Appreciate you guys. Thank you.
Okay, thanks. Thanks.